Welcome to the Centers for Medicare and Medicaid Services Post-Acute Care Provider Training Series. My name is Dave Nolly and I'm moderating today's training session on MDS 3.0. Specifically, today's training will focus on coding of Section I, active diagnoses. Before we begin discussing this section of the MDS 3.0, I would like to offer an important reminder. While the 2013 MDS 3.0 educational programs provide great information about select sections of the MDS 3.0, it is critical to remember that the RAI User's Manual, which is available at the CMS website, must be used routinely by assessors to ensure accuracy in coding the MDS 3.0. Specifically, Chapter 3 of the RAI User's Manual is where intent, rationale, and step-by-step coding instructions can be found for each section and item in the MDS 3.0. The goal of Chapter 3 is to facilitate the accurate coding of the MDS 3.0 and to provide assessors with the rationale and resources to optimize resident care and outcomes. Before going any further, I would like to introduce our panelists for today. Joining me today are Jennifer Pettis and Shelley Ray. Hello, ladies, and thank you for joining us today. In addition to discussing the coding instructions for Section I, Jennifer and Shelley will field some frequently asked questions from the provider community. So let's start with you, Jennifer. Would you share with us the intent of Section I? In other words, why is this an important part of the MDS 3.0 assessment?
Sure, Dave. I'd be happy to. According to the RAI User's Manual, the items coded in Section I reflect diseases that have a direct relationship to the resident's current functional status, cognitive status, mood, or behavior status, medical treatments, nursing monitoring, or risk of death. One of the important functions of the MDS assessment is to generate an updated, accurate picture of the resident's current health status at regularly scheduled intervals.
The phrase direct relationship is noted in the intent statement. What exactly does that mean?
That's an excellent question, Dave, and that concept is critical to understand in order to accurately code Section I. A disease that drives the resident's plan of care is considered one that has a direct relationship to the resident's status and therefore is considered to be an active diagnosis. In the RAI User's Manual, there are specific criteria used to determine and document resident diagnoses, and then to determine if a documented diagnosis is active. There are several examples provided that demonstrate this concept. This is what we'll be discussing in today's program. Disease processes can have a significant adverse effect on an individual's health status and quality of life. When coding Section I, the assessor identifies active diseases and infections that drive the current plan of care and include them on the MDS 3.0 in this section.
Shelley, please tell us about the steps that the assessor takes to accurately code Section I.
There are two very distinct steps with specific look-back periods for coding Section I. In the first step, the assessor must identify diagnoses. This will be accomplished by ensuring a physician-documented diagnosis in the last 60 days. It is important to note that the physician-documented diagnoses requirement can also be met by a nurse practitioner, a physician's assistant, or a clinical nurse specialist if allowable under state licensure laws.
You know, Shelley, we received a question from a provider in New York about this first step. They wrote, "We have a nurse practitioner that works with our physician. How do I know if the physician documented diagnosis criterion is met with the nurse practitioner's notation of a diagnosis?"
That is a great question, and it is definitely a state-specific one. Your state nursing board, State Nurse Practice Act, or state survey agency should provide you with information as to who can document diagnoses in the medical record. It is the state RAI coordinator who can further assist in understanding the criteria and coding instructions provided in Section I. The state RAI coordinator contact information can be found in Appendix B of the RAI User's Manual. Sometimes providers ask about potential medical record sources of physician diagnoses.
That's right. For example, a provider in Wyoming asked, if the care plan identifies a diagnosis of depression and the signed physician orders indicate that the physician has reviewed the plan of care, does this meet the criteria of a physician-documented diagnosis provided the physician's orders were signed within 60 days of the assessment reference date, or ARD?
A signature associated with a physician review of a care plan is not an acceptable substitute for a physician-documented diagnosis, even if there are physician orders signed within 60 days of the ARD. The physician's orders that document a diagnosis, medication, or treatment are acceptable, as are the following sources within the medical record: progress notes, history and physicals, transfer documents, discharge summaries, diagnosis and problem list, and other sources as available. If a diagnosis problem list is used, only diagnoses confirmed by the physician should be entered. The RAI User's Manual offers a couple of other key points about this section. Although open communication regarding diagnostic information between the physician and other members of the interdisciplinary team is important, it is also essential that diagnoses communicated verbally be documented in the medical record by the physician or other healthcare practitioner as allowable under state licensure laws to ensure follow-up. Diagnostic information should be verified and documented in the medical record by the physician. Past history obtained from family members and close contacts should also be documented in the medical record to ensure validity and follow-up by the physician.
Thanks, Shelley. Jennifer, could you provide an example of this?
Sure, Dave. Let's say a resident's daughter communicates to the facility social worker that the resident has a long history of depression. The daughter goes on to report specific signs and symptoms that the staff should be aware of, as these symptoms represent the need for additional measures to be taken to avoid a potential reoccurrence of the resident's depression. The social worker informs the physician of the discussion with the family. The physician then contacts the resident's psychiatrist, who provides the history. The physician then documents the diagnosis of depression in the resident's medical record. As long as the diagnosis is physician documented in the last 60 days, the first qualifier has been met.
Okay, that was a great explanation of the first step of diagnosis identification. Can you describe the second step in determining if a diagnosis should be included in Section I of the MDS 3.0?
Sure. The second step of this two-step process is to determine whether diagnoses are active. Active diagnoses are those that have a direct relationship to the resident's current functional, cognitive, or mood or behavior status, medical treatments, nursing, monitoring, or risk of death during the 7-day look-back period. The assessor will not include conditions that have been resolved, do not affect the resident's current status, or do not drive the resident's plan of care during the 7-day look-back period, as these would be considered active diagnoses.
We've heard examples of potential sources for physician diagnoses. Shelley, do you have suggestions for where the assessor might find information that indicates the diagnosis is active in the last 7 days?
Some potential sources include transfer documents, physician's progress notes, recent history and physicals, recent discharge summaries, nursing assessments, care plans, medication sheets, doctor's orders, consults, and diagnostic reports. This is not an all-inclusive list, but rather just some of the potential places in the medical record that the information might be located. Let's continue our earlier example in which the resident's daughter reported their depression. The team was successful in obtaining supporting information from the resident's mental health provider, which was added to the medical record. The care plan was updated to include the information from the daughter and the mental health provider, including necessary monitoring and measures to take. If the signs and symptoms of depression that were reported prior reoccur. Taking all this information into account, it can be said that this diagnosis is active for the resident.
Shelley, we have a question from a provider in Nebraska regarding determining if a diagnosis is active. This is a resident-specific question about Ms. A, who is a new resident in the facility. Her diagnoses include morbid obesity and a stage 3 pressure ulcer. Ms. A is receiving protein supplements which were ordered by the physician after the consultation with the facility dietitian to aid in the healing of the stage 3 pressure ulcer. Ms. A is also receiving a weight reduction diet per her request and after physician consultation. After reviewing her albumin level from earlier this month, the physician noted Ms. A has protein malnutrition and requested the dietitian reevaluate Ms. A's nutritional plan. Adjustments to the dietary approaches to Ms. A's plan were made, approved by the physician, and have been updated on Ms. A's care plan. Should I-5600 malnutrition be coded?
Since we know she has been diagnosed with protein malnutrition by a physician during the last 60 days, the next step to take is to identify whether the diagnosis is active in the 7-day look-back period. Ms. A is receiving additional protein to address newly diagnosed hypoalbuminemia and will continue with protein supplements to aid in healing her stage 3 pressure ulcer. Nutritional plan adjustments were documented in Ms. A's care plan to address the diagnosis of protein malnutrition. This is all evidence of an active diagnosis for protein malnutrition in the 7-day look-back period.
That is a great example, Shelley. Thanks. In the examples we have just heard, references have been made to specific diagnoses and their correlating item numbers that are found in Section I of the MDS 3.0. Jennifer, will an assessor find a comprehensive list of diagnoses on the MDS 3.0?
There are many diagnoses listed by major disease category on the MDS 3.0, and there are some diagnoses listed that have examples of diseases to be included in those diagnoses. It's important to note that these examples are not all-inclusive. For example, I-0200 anemia includes anemia of any etiology, including those listed, which are aplastic, iron deficiency, pernicious, or sickle cell. The assessor will check off each active disease, being careful to check all that apply. In addition to all of the listed diagnoses, there is a none of the above option, as well as I-8000, other additional active diagnoses, where the assessor can enter the International Classification of Diseases, or ICD, code of any disease or condition that is not specifically listed.
Now, you mentioned that some of the diagnoses listed on the MDS 3.0 have accompanying examples of diseases to be included. Here's a question from a provider in the state of Florida about a diagnosis that does not have additional examples. If a physician gives a diagnosis of quadriplegia, such as unspecified quadriplegia due to paralysis of all 4 limbs, spinal cord injury, or other cause, then it would be coded in Section I, correct? Shelley, can you give us some insight into coding quadriplegia?
If there is a physician-documented diagnosis of quadriplegia within the last 60 days, and it is still an active diagnosis in the last 7 days, it is to be coded on the MDS. Quadriplegia is the complete paralysis that affects all 4 limbs caused by injury to the spinal cord in the area of the neck. It is usually identified by which vertebrae have been injured in the cervical spine and how complete the severing of the spinal cord may be. A diagnosis of quadriplegia unspecified may be used if an injury is old and there's no medical documentation related to how the spinal cord injury actually happened. Facilities in general should work to clarify any nonspecific diagnoses as much as possible. For MDS 3.0, item I-5100 quadriplegia is not coded as a primary diagnosis in Section I when it is not caused by spinal cord injury. Let's consider a specific example that may help to clarify this point further. Mrs. Z has end-stage Alzheimer's disease and can no longer move any of her limbs. Ms. Z is dependent on facility staff to assist her with all of her activities of daily living. In this case, Ms. Z is an individual who has a severe debilitating diagnosis with a functional deficit that can render her functionally immobile. This functional immobility may seem comparable with what would be seen in a quadriplegic. However, it is the diagnosis of end-stage Alzheimer's that will be coded on the MDS in I-4200, Alzheimer's disease, and not I-5200, quadriplegia. It would be inappropriate to code the functional status or ADL deficit associated with Alzheimer's disease under I-5100, quadriplegia. Similarly, a resident with a diagnosis of cerebral palsy, spastic quad type, would be coded under I-4400 cerebral palsy and not under I-5100 quadriplegia. A resident with severe rheumatoid arthritis would be coded under I-3700 arthritis and not under I-5100 quadriplegia. If there is a physician-documented diagnosis of functional quadriplegia that is secondary to a debilitating disease, this diagnosis can be coded under I-8000. Other additional active diagnoses.
Let's answer one more provider question before we move on. This question comes from Maine. The provider asked about a specific resident, Mr. F. The facility staff reported that Mr. F has been receiving no medications or therapies related to a stroke that occurred 2 years ago. He does, however, have right-sided weakness and requires some adaptive equipment and assistance from facility staff to perform activities of daily living. How should this be coded in Section I? Jennifer, can you provide some insight for this provider?
Regarding a resident with hemiplegia or hemiparesis secondary to cerebrovascular accident, CVA, or a stroke, the CVA is not considered the active diagnosis if the CVA itself has resolved. That is, the resident is receiving no treatment such as medications and/or therapy to manage continued symptoms from the stroke. However, deficits, as in the case of Mr. F, the hemiparesis, are a result of the stroke that occurred 2 years ago. If the current plan of care is addressing deficits associated with hemiplegia or hemiparesis and all the requirements for coding the diagnosis as active are met, this should be captured in item I-4900, hemiplegia or hemiparesis, and not under I-4500, cerebrovascular accident.
We've heard about the 60 and 7-day look-back periods associated with Section I. Do those look-back periods apply to all diagnoses listed on the MDS 3.0?
Dave, there's one exception to these look-back periods, item I-2300, urinary tract infection or UTI. Not only does UTI have a look-back period of 30 days for the active disease instead of 7 or 60 days, it also has 4 elements that the assessor needs to identify in order to code this diagnosis. The first element is that the diagnosis of UTI has to be present in the 30-day look-back period. Like all diagnoses, this can be made by a physician or other authorized licensed staff as permitted by state law. Next, the assessor needs to identify at least one sign or symptom attributed to UTI. Potential signs and symptoms are numerous and can certainly vary from one resident to another. A few common symptoms include fever, urinary symptoms such as painful urination or urinary frequency, pain or tenderness, mental status changes including confusion, and changes in urine characteristics such as color or clarity. Significant laboratory findings need to be determined by the attending physician, as the level of these findings may vary amongst individuals. Physicians should also determine whether or not a culture should be obtained. In other words, there may or may not be a need for a urine culture. It's the physician who determines the significance of any laboratory testing in conjunction with the individual's presenting signs and symptoms, and whether the combination of these findings are sufficient enough to constitute the diagnosis of UTI. The fourth element is that a medication or treatment for a UTI must be administered within the last 30 days.
Before we wrap up today's presentation, does the RAI User's Manual provide any additional information or tips for our audience?
One thing that is really important to remember is that the RAI User's Manual does not provide definitions of diagnoses. This was an intentional omission, as it's up to the physician that must make a determination and document the active diagnoses for all residents in the facility according to their assessment of the resident.
Shelley, what tip can you offer our viewers?
Determining if a diagnosis is active in the 7-day look-back period can be challenging for some assessors. While the physician may specifically indicate that a diagnosis is active, it is very likely that the assessor will need to look for other sources of information that may document a particular diagnosis. There also may be documentation of a sign or symptom attributed to a diagnosis. It is important to remember, however, that sometimes signs and symptoms can be nonspecific and could be caused by a variety of diseases or conditions. For example, A productive cough would confirm a diagnosis of pneumonia, if specifically noted as such by the physician, and perhaps radiological reports. In other words, signs and symptoms alone do not stand on their own. They must be specifically attributed to a particular disease or condition. All diagnoses documented in the medical record and subsequently reported on the MDS must be those that have been confirmed by the physician.
Jennifer, what if a resident takes a medication for a specific diagnosis? Does that provide the assessor with an indication of the disease being active?
A medication indicates active disease if that medication is prescribed to manage an ongoing condition that requires monitoring or is prescribed to address symptoms associated with a particular condition. For example, if a medication is prescribed for a condition that requires regular staff monitoring of the drug's effect on that condition, then the prescription of the medication would indicate active disease. Yet the disease itself would still need to be confirmed and documented in order to be coded on the MDS.
I see. It seems that there are a lot of potential sources where the information can be found to determine if there's an active diagnosis, and the assessor needs to be aware of these sources in order to code Section I correctly. We've covered a lot of information in today's training and answered some great questions from the provider community. We hope that you have found this training on Section I to be helpful. Ensuring MDS 3.0 accuracy is critical to ensuring accurate care plans, quality measures, and much more. If you have additional questions regarding Section I, please refer to the RAI User's Manual. If you need further clarification, please feel free to contact your state RAI coordinator. The work that you do is important to ensure that the best possible care and quality of life is afforded to the residents in America's nursing homes. To all of you taking part in this educational activity, I would like to extend a final thank you on behalf of myself, Jennifer, Shelley, and CMS.